Hello, and welcome to this IARS virtual education webinar on preparing the mind for surgery, examining the potential for physical, cognitive, and mindfulness training to improve postoperative outcomes. My name is Christopher Hughes. I am coming from Vanderbilt University Medical Center, and I'll be the moderator for the webinar. Here are my affiliations. I do have some financial relationships, but no conflicts of interest for this talk. The outline will be this quick introduction, and then talks on physical prehabilitation, cognitive prehabilitation, mindfulness, challenges and future directions, and then a live question and answer discussion session at the end. First off, I just want to take a quick second to say thank you to all the providers out there. It's been really a crazy couple years stressing our system. So thank you for all that you're doing for our patients and for the field of anesthesiology. So we're performing surgery to fix something, right? To take away pain, to remove cancer, make the patient better. But it needs to be more than just getting through or surviving the surgery. Our patients have this prioritization to want to live independently, to return to activity, to keep their brain function. But the surgeries that we're doing and then the hospital stays affiliated with them can lead to significant impairments. Cognitive decline in up to 50% of high-risk patients that could be associated with decreased employment, decreased quality of life, and even death. Functional decline also in about 50% of patients, including up to 12 months with having difficulties in activities of daily living. The current status of our medical system is to accommodate these new impairments through rehabilitation, using assist devices, and discharging to facilities and rehab instead of going to home. But is there a way that we can do this better? What if we can do more before the surgery to prevent these impairments from happening in the first place? And that's where the concept of prehabilitation comes in. So can we increase cognitive reserve? What about enhancing functional capacity and improving the patient's ability to tolerate the stress from the surgical course that we're about to embark on? So our first talk is going to be by Dr. Kimberly Rengel. Dr. Rengel graduated medical school from the University of Texas in Houston. She did residency and critical care fellowship at Vanderbilt University Medical Center, where she stayed on as faculty and is now assistant professor. Her research interests include functional impairments and sarcopenia after major surgery and critical illness. And her talk is on physical prehabilitation to improve postoperative functional capacity and cognitive function. Our second talk will be by Dr. Michelle Humeidan, who completed her MD and PhD program at the University of Kentucky, and then went to residency and fellowship in neuroanesthesiology at Ohio State, where she joined the faculty there in 2015. She is an associate professor there now and is the medical director of enhanced surgical recovery. She is focused on both preclinical and clinical neurological research, and she'll be talking to us on cognitive prehabilitation to prevent postoperative delirium. Our third talk will be by Dr. Balachundhar, who is a professor of anesthesiology at Harvard Medical School. He did his medical and anesthesia training in India and then additional post-op training at Beth Deaconess, where he also did a cardiac anesthesiology fellowship. And he stayed on there as faculty, where he's now a professor and director of the Center for Anesthesia Research Excellence and the Center for a Conscious Planet. He is now the Ellison Jeep Pierce Chair of Anesthesia and will be talking to us on mindfulness training to improve postoperative outcomes. Our fourth and final talk will be by Dr. Brian O'Gara, who completed medical school at Boston University. He then did residency and fellowship in critical care medicine at Beth Deaconess, where he stayed on as faculty and is now assistant professor of anesthesia. His interests include leveraging innovative technology, such as computerized cognitive training and virtual reality, to prevent postoperative complications. And he's going to be talking to us on challenges to feasibility and implementation of prehabilitation programs and then future directions. Then after the four talks, we'll have a live discussion and question and answer session. So please type in your comments in the chat or save them for the live discussion at the end. Thank you very much for joining and look forward to the discussion at the end. Thanks very much.
Good afternoon, and thank you for this opportunity to speak with you today about physical prehabilitation and the opportunities to improve both postoperative functional capacity as well as cognitive function. I have no financial relationships to disclose. I do not talk about any off-label or investigational use medications, and I am currently funded through the support of the Vanderbilt Center for Muscular as well as Cognitive Function. I have no financial relationships to disclose. I do not talk about any off-label or investigational use medications, and I am currently funded through the support of the Vanderbilt Center for Musculoskeletal Research, as well as the Vanderbilt Faculty Research Scholars. Today, I hope that after my talk, you're able to describe some of the trajectories patients face in recovering from major surgery, review some of the current studies and practices in physical exercise prehabilitation, and then discuss the role of physical exercise in promoting perioperative brain health in the future. This talk applies particularly to the aging population. We know that people over the age of 65 are becoming an increasingly higher proportion of the total population, but they also consume a disproportionate amount of healthcare, including 43% of all hospital days, 30 to 35% of all procedures, and require more than 19 million major surgeries every year. But it doesn't always end as well as they think or hope that it will, and this has gained the attention of the lay press. And we know that when patients come to us for healthcare and for procedures, what they really hope to do is return to an acceptable standard of independent living and the activities that they loved before. And unfortunately, we're not always able to deliver on that goal. And in fact, we know from a landmark study by Lawrence and colleagues that many patients start with a baseline level of ability or disability in activities, very basic activities such as eating and transferring from bed to a chair, and then more advanced activities that incorporate both physical and cognitive functions, such as maintaining a household or managing one's medications. And all patients experience an expected decline at 1 week after an operation in their ability to perform these tasks. But what was so surprising is that 3 weeks, 6 weeks, 3 months later, many patients were still experiencing difficulty in completing these tasks, and it took almost 6 months to return to baseline, and some patients never did return to their baseline. And similarly, patients with varying levels of disability going into an operation experienced very different levels of recovery. So those with no disability at baseline had a few new disabilities after a major operation, but by 3 months those resolved, and that was the most rapid improvement. And then improvement became more gradual if it happened at all, and many patients were left with new disabilities in addition to what their baseline was after undergoing major surgery. Similarly, we know that patients across all age groups experienced some level of cognitive dysfunction in this particular study at discharge from the hospital, but by 3 months that had fairly well resolved in young and middle-aged groups, but 13% of older adults over the age of 60 were left with persistent cognitive dysfunction 3 months after an operation. And our current status for managing this is sort of a wait and see and then treat tactic, where we wait to see how a patient weathers a surgery, we let them undergo physical or occupational therapy evaluation, and then we refer them to rehabilitation, send them home with assistive devices, discharge them to a facility in extreme cases, or teach them how to accommodate a new disability. But the point is that we wait for patients to lose function that they previously had, and then work through rehabilitation to restore lost skills and regain self-sufficiency, and it may not always be successful, which has brought the idea of prehabilitation to the forefront, where we might be able to head this off prior to an operation. So prehabilitation is the idea of enhancing functional capacity before a surgery and improve tolerance to the stress of that surgery, so it prevents that steep decline after an operation with a steep hill to climb to recover afterwards. And so it makes the insult of surgery less, and also hopefully allows patients to start from a slightly higher level of function. So again, that decline is less noticeable to them. And prehabilitation programs are highly, highly variable, and they are performed in different populations. And so there's very little consistency in the literature right now. But the basic premise is that they incorporate some form of physical exercise, whether that be aerobics or high intensity interval training, resistance training, sometimes both. And then many of the programs also incorporate an element of nutrition management and improvement, as well as mindfulness. And these programs are often performed 3 to 6 weeks before an operation, usually 2 to 3 times per week, particularly for the physical exercise component. And they have shown results with improved functional status and fewer complications. For example, in a population of esophagogastric cancer surgery patients, completing this physical exercise program for an average of 36 days before their operation led to an improved 6-minute walk distance, indicating that they had a higher endurance and functional capacity before their operation, but also it persisted after their operation as well. Similarly, in a group of hepatic or pancreatobiliary surgery patients, completing a prehabilitation program led to an increase in their endurance, as evidenced by their 6-minute walk distance, and also increased their total muscle to fat ratio, showing a change in body composition and higher metabolic tissue. And this translated into an change in outcomes where the prehabilitation group had shorter postoperative hospital stays. And finally, in high-risk patients having major abdominal surgery, completing a prehabilitation program led to an increased aerobic capacity and a decrease in immediate postoperative complications, but also in a very exciting discovery, the effects persisted over time because completing that prehabilitation was protective against 30-day hospital readmission, and the participants showed a sustained enhancement of their aerobic and capacity and physical activity up to 6 months after surgery. The tie between physical exercise and cognitive function has not been well established in the perioperative population, but we do know that in community-dwelling older adults, over the age of 50 in this particular review and meta-analysis, that engaging in physical exercise was associated with improved cognitive function across multiple domains, regardless of their baseline cognitive status, whether they were cognitively normal or had mild cognitive impairment. And the findings of this study showed that a combination of aerobic and resistance training of at least moderate intensity for around 45 minutes per session as many days a week as possible showed the greatest benefit. Similarly, in a community dwelling group of older adults over the age of 65 with cognitive impairment, participating in physical activity in this particular meta-analysis showed that the patients gained in strength and physical fitness, but also in cognitive performance and measurements of behavior. So there's promise that physical activity is very beneficial to the brain. While this work has not been translated yet into the surgical population specifically, there has been some preclinical work in mice showing that mice who trained for 5 weeks on a ladder climbing protocol with progressive weight loading, so an increase in the difficulty of their physical activity, who then underwent a laparotomy under sevoflurane, the intervention group showed improved cognitive function and synaptic plasticity, as well as reduced neuroinflammation, which is thought to be partially responsible for cognitive dysfunction after surgery. And similarly, in a rat model that looked at both aged and young rats in a sedentary versus an environmentally enriched setting, where they had access to a training wheel for physical activity and mazes to complete that included cognitive activity for 14 days before a surgery, the aged rats in the sedentary group who received surgery did show memory deficits and increased inflammation in the hippocampus, but those aged rats who were exposed to this preoperative environmental enrichment program actually had an attenuation of those changes, but it made no difference in the young adult rat group. And we do know from the community that you can also combine both physical and cognitive training and see benefits in cognitive function over time. So in a community dwelling group that completed 1 hour of physical training and 35 minutes of cognitive training 3 times a week for 12 weeks, they found better memory and attention and less depression in this group of older adults. So our research group decided to design a study, initially a pilot feasibility trial, to look at the effects of a combined physical and cognitive prehabilitation program in surgical patients. And we randomized patients either to an intervention with a stepwise progressive exercise program that came out of a binder that they took home with some resistance bands. They engaged in weekly phone calls from a physical therapist to help them stay on track and choose the correct level of programming, and then took home an iPad with an adaptive computerized cognitive training game, versus the active control group who had no prescribed physical exercise, played a control game with only trivia functionality, and did receive weekly phone calls from a physical therapist. We had 25 patients overall who underwent surgery and completed their 1-month follow-up, and found that patients would engage in at least 1 day of physical activity or cognitive activity. About 80 to 90% of patients would do this at least once before an operation. And of all of the days available before an operation, participants would participate in 4 to 5 days per week of exercise and about 3 days per week of cognitive activity. And though we were very much underpowered to detect a difference, we actually found a tendency towards improvement across all of the cognitive domains that we tested, and either improvement or no difference in the physical outcomes that we tested. And this led us to design a much bigger, more robust trial of a comprehensive cognitive and physical training program where we randomized adults over the age of 60 awaiting major non-cardiac surgery to an intervention group that again does computerized cognitive training, as well as a prescribed physical therapy program in a group setting over Zoom. So we're utilizing telehealth and monitoring their heart rate and activity using a Fitbit, versus a control group that plays a sham game with no cognitive training functionality, and participates in a basic stretching activity over Zoom 3 times per week. And we enrolled them 2 to 8 weeks before surgery out of our high-risk surgical encounter clinic, and then they engage in their prehabilitation training. They have their operation, we collect data all the way across the board, and then they actually complete another 3 months of the program, at which point we perform assessments at 3 and 12 months after surgery. So far, we started enrollment in October of 2021 and have 63 of the 250 participants enrolled, so stay tuned for more exciting data and results to come from that study. So hopefully now you have a little bit better idea of some of the trajectories that patients face after major surgery in their recovery period, and how current prehabilitation programs are designed, but how we might better design them to start thinking about the effects of physical exercise in perioperative brain health. And so I appreciate your time and attention. Thank you to IARS for this opportunity, all my mentors and funding sources. And here's a picture of our team, and I look forward to answering your questions here shortly. Thank you.
Thank you. I am so excited to talk to this group about the use of cognitive prehabilitation to prevent postoperative delirium. I'm Michelle Humeidan. I'm currently at Ohio State University. I want to disclose that I do have a no-cost utilization arrangement with Lumos Labs. They're the creator of the Lumosity brain exercise software that I use for the neurobics trial. And I will be discussing the investigational use of this brain exercise software for the prevention of postoperative delirium. In our brief discussion today, I want to go over basic cognitive prehabilitation concepts and also review the results of the neurobics trial. So anesthesiologists are very interested in optimization prior to surgery. If we have time, we want to make sure all of the organ systems are maximally prepared to tolerate the stress of surgery. As a medical student, I was really struck by the fact that even though we talked about the heart, lungs, kidneys, blood, anemia, we never talked about the brain. And I thought that was really a missed opportunity, especially as a neuroscientist that's always been interested in cognition. So I am very happy to see that focusing on the brain, perioperative brain health, is now becoming something of renewed interest. And a lot of researchers are actively exploring this because delirium is a very important problem. joint consensus statement published by Dr. Hughes and colleagues points out several important predisposing factors for postoperative delirium. In the neuropsychological category, I want to highlight one factor in particular, which is a limited cognitive reserve. Cognitive reserve is a construct of things that support or diminish it over the course of one's lifespan. So things that support cognitive reserve are physical activity, social interactions, things that keep the mind active. And diminishing cognitive reserve can be overall poor health, poor sleep, nutrition, substance abuse, and depression and anxiety. Several of these factors are very important in the perioperative space and something that we really are starting to focus on as ways to improve neurocognitive recovery after major surgery. So cognitive reserve can be thought of as a protective factor that keeps patient A from falling below a functional impairment cutoff, whereas patient B falls below that cutoff after both of them receive a major stressor like surgery. When I think about cognitive reserve, I break it down into two categories: maintaining and supporting cognitive reserve that's already present, and augmenting cognitive reserve to actually improve this protective factor before surgery. The Hospital Elder Life Program is one of the most important programs for prevention of delirium, and it's been applied to surgical patients very successfully. The Hospital Elder Life Program focuses on postoperative interventions. And so if you're interested in augmenting cognitive reserve and actually building cognitive reserve for a prehabilitation program, one of the things that has promise is the use of cognitive exercise in the form of gaming, particularly active gaming in older patients especially. So this got my attention, this relationship between gaming, brain exercise, and cognitive reserve. And so I came up with the idea for the Neurobics trial. The primary objective of the Neurobics trial was to test the influence of preoperative cognitive exercise using the Lumosity application compared to no intervention on the incidence of postoperative delirium in an elderly patient population having major non-cardiac, non-neurological surgery. We screened just under 700 patients for this trial. We randomized 268. All patients were cognitively normal at baseline. We did assessments on them, including the mini mental status exam, to exclude patients that had any cognitive deficits at baseline. 134 and ultimately 125 were randomized and subsequently analyzed in the intervention group. 134 were randomized to the control group, with 126 subsequently being analyzed. So if you're not familiar with the Lumosity app, it's actually a very fun, interactive platform that's user-friendly and dynamic. So it challenges the patients based on the users, based on their performance. And it hits several different areas of cognitive domains, including speed of processing, memory, and the patients really liked this activity. It was intuitive, and we didn't see issues with our older patients engaging overall with the application. So the results of the trial are summarized here. As I mentioned, we had 268 that were ultimately randomized, split equally between the intervention group and the control group. Our median age was 67 years, and our median tablet-based gameplay of the Lumosity software was 4.6 hours, so just under 5 hours. Our incidence of postoperative delirium as determined by the CAM-ICU, Memorial Delirium Assessment Scale, or chart review, was 23% in our control group. It was 14.4% in our intervention group. The delirium onset day, duration, and total delirium positive days were not different between the two groups. But this analysis is limited because it's focusing on just the patients that were delirium positive, which was a small group of overall patients compared to the trial at large. What is interesting is if you look at that 5 hour or so cutoff, there seems to be a less gaming equals more delirium risk and more gaming equals less delirium risk phenomenon that we're seeing. It's almost a dose effect. For the patients that played less than 5 hours, the delirium rate was 18.4%. But for the patients that played more than 5 hours, the rate was only 10.2% and 9% for our highest gamers. We tried to understand if there were factors contributing to less or more gaming in the patients that we could determine based on our baseline demographics, and we were not able to find any of those. Overall, the age was similar, the baseline education level, comorbidity burden, their many mental status exam performance, which is not surprising since they were all cognitively normal at baseline, and also their depression screening risk. So we weren't able to understand why some patients played less and some more, but we were able to start thinking about what that dose effect might mean for future studies. So there's been a lot of discussion about the feasibility of brain exercise in older patients in particular for the prevention of postoperative delirium. The Neurobics trial, we didn't meet our 10-hour request of gaming, but the 5-hour level that was achieved might actually be enough to see an effect based on our data, and certainly warrants more investigation. This is similar to what some of the other feasibilities have shown as far as the threshold for what patients are reasonably able to do before surgery. Some of the strengths of the Neurobics trial are that it was randomized. We had a really high rate of in-person delirium assessment completion. It was in a rigorous study designed to detect delirium. Most of our patients met basic compliance with the intervention, meaning they played at least some brain exercise, even though the overall amount was not what we asked. We looked at delirium across the important postoperative window from 0 to 7 days if patients were still in the hospital. And as I mentioned, the overall study design was rigorous. So even though it's a lot of work is still left to be done to understand which patients this is best for and what the appropriate dose is, the Neurobics trial is definitely a very good start for us. So as I mentioned, we covered some cognitive prehabilitation concepts and reviewed the results of the Neurobics trial. We are continuing to analyze the results and have more to publish in the future. And I appreciate everyone's time.
All right. Can you hear me, Kristen?
Yeah.
Okay.
You just need to get out of notes mode.
Sorry, I didn't catch the next one. I think I have the right screen to you, right? It's good or no?
It looks like you're in notes mode. You can
Oh,
do it in presentation mode.
all right. It's better probably now.
Yes.
Okay. Thanks, everyone, and thanks to IARS and this elite panel to share my experiences about mindfulness training to improve postoperative outcomes. I am from Beth Deaconess Medical Center. I do have financial relationships. My research is funded by NIH, philanthropy, Massimo, Merck, and none relevant to this particular talk. So everybody talked about effect of, for example, exercise on the brain, but I'm just going to talk about what can mindfulness training, that is effective brain exercise itself, can do to other organs and improve the postoperative outcomes. So this is one of the comprehensive systematic review that normally that we don't see, but this is in the perioperative medicine and just recently came out. So in short, it improves pain relief as well as physical functioning. So let's just see that in detail. So what are the domains where mindfulness can make a difference? One is acute postoperative pain, which every one of us is concerned about, stress, anxiety, and depression. As you all know, especially after cardiac surgery, even after 1 or 2 years, there's a significant percentage of people, up to 20 to 30% of people are depressed. So it is a very relevant topic in the perioperative period. And better respiratory reserve with techniques such as breathing meditation, better sleep, perioperative neurocognitive decline that everyone is interested in, and also optimal inflammation response. So let's just focus on the pain studies. I'm just giving extreme scenario here where, the joint surgery recipients, you can look at pain after a year. How can mindfulness training that was started just before surgery for a period of 8 weeks or so can affect pain that is felt after a year? It's true, this is a randomized controlled trial, and people have actually shown that mindfulness training can improve both pain as well as function at 1 year, which may be very relevant from the patient point of view. So immediately after surgery, there is acutely, you can see that mindfulness training, i.e. you can see in this blue panel, or the hypnotic surgical techniques can reduce the pain intensity in the acute setting, reduce the unpleasantness, and also the anxiety associated with it. So there are about 13 or 14 studies that looks at mindfulness meditation and perioperative outcomes. So in general, you can think of meditation or mindfulness as two broader groups. One is focused attention, and the other one is open monitoring, where you just sit down and you just let the mind go of itself. You're not focused on any particular thing, and there is more contemplation about it yourself. So how can these things affect some of the aspects of what we are interested in? For example, in open monitoring, momentum, non-evaluative awareness of whatever arises in your mind, meditators are taught to fully experience the intensity of sensory event. Seems like after, let's say, 8 weeks of training with 4 days or so of daily training, it seems to reduce unpleasantness and also same pain intensity in this particular study. Focused attention do sense of detachment from ongoing affective states and enhance cognitive control. So you're focused on a particular point or a breath or anything else a particular school of yoga or meditation that can teach you about. It seems to attenuate pain by altering the elaboration of nociceptive information to pain. Let's just look at this particular pain aspects a bit in detail. So seems like the subjective experience of pain, known for thousands of years, can significantly be altered by mindfulness meditation. And with this text, consider this as the arrow, unique ability to fully experience the sensory aspect of pain. That is the first arrow. The second part is let go of the evaluation of the pain itself. So you can feel the pain, but may not ask for much of the pain control or analgesics. So you're not suffering from it, but you may have the acute pain from there. There's also this study that's published way back in 1980 about Nepalese porters who significantly have higher pain thresholds in response to pain-evoking electrical stimulation. Just because they're living in a high altitude doesn't mean that they're actually practicing any mindfulness meditation. This is a very good study that was published in Journal of Neurosciences in 2011 that included 15 healthy volunteers, 6 males and 9 females, looking at MRI imaging. So they went through an elaborate protocol where there's a psychophysical training session followed by MRI session. So initially you tell them about what is the visual analog scale, what is the thermal stimuli they're going to get, hot and cold stimuli they want to get, how is the MRI stimulus going to be, like the sounds that they might get during the MRI. Then the pre-meditation training, they go through block 1, block 2 of image acquisition, simply getting the anatomical scans. And block 3 is with the heat or neutral stimulus, and you get similar scans in them. Then you go through training sessions, so 1 to 4 sessions of meditation training. And then after you do the training, then you put them into the MRI scanner and introduce them to the sounds. Then you go and acquire post-meditation training MRI session. So pretty elaborately set, well-designed trial. What does it show, right? 4 meditation training sessions of 20 minutes. And you can see that the intensity ratings, as well as the unpleasantness ratings, are actually low in patients or participants who had the mindfulness training. What exactly happens at the brain level? What did the MRI show actually? There is a significant overlap between the pain and meditation areas. You can see here that the anterior cingulate cortex and the anterior insula and posterior insula, especially the anterior insula and the orbitofrontal cortex and the anterior cingulate cortex, there is significant overlap of these two, potentially, giving a mechanism that probably meditation influences the cognitive modulation portion. So when you look at pain intensity, it's the anterior cingulate cortex and anterior insula. Pain unpleasantness is the orbitofrontal cortex stimulation or downregulation of the thalamic stimuli. So let's just look at stress, anxiety, and depression portion. So this work comes from a cardiac surgical group at All India Institute of Medical Sciences, New Delhi. A pretty large study done in almost 73 intervention group and 74 controls. And they gave this training before the surgery for quite some time. They, there's equal distribution at baseline, but look at the anxiety scores at before they started the training session, before the surgery itself, and after the surgery and at discharge. You can see in the meditation group and in the control group, a significant difference in the anxiety scores and also in the blood cortisol level, really showing that all these have a basis much more than just the neuropsychiatric evaluation or the scores itself, which are more subjective. We, in our group, with the Center for Conscious Planet, started 2 years ago. We have done in the general population, you can look at 12 minutes or 15 minutes of guided meditation, which is supposed to be the most effective way of giving meditation to the novices, and look at anxiety scores and depression scores. You can divide them into 3 different categories: severe, moderate, mild, and none. Even with just 2 weeks of training with about 12 to 15 minutes a day for done at least 4 to 5 days a week, you can actually see that within 2 weeks, the severe levels go down to milder levels and the moderate levels become milder levels. So anxiety definitely decreases, and so is the depression. So this was recently published in Frontiers in Psychology. We have done this also in our own surgeons and also anesthesiologists. You can see that total mood disturbances, this is at 7 a.m. in the morning in a grand rounds, even with one training, the mood disturbances just goes down for that particular training. How long it lasts, it's not certain because you're just doing one training, but if you do it on a daily basis, it is supposed to last longer. Most important thing is immediate loss of negative subscales in these people, and just goes down significantly. This is done in over 150 participants that include well-trained anesthesiologists and surgeons at morning 7 a.m. So when you look at these interventions a little bit more deeper, they can actually last longer. If you do these retreats and deeper levels of meditation for longer periods, you can actually have these effects lasting for 3 months. You can see those who are baseline depressed have a relief from this after a 7-day retreat for over 3 months. Similarly, in anxiety, you can see the same story there. Most important thing to notice here is people who have been practicing mindfulness meditation or yoga, they have 1/3 of CRP levels compared to the controls who are similar age, gender, and zip code matched controls practicing similar types of professions. So that is something to note about the inflammation piece. So now, what is the mechanism for alleviating depression? It seems like meditation can increase the blood flow in the prefrontal cortex, increase activation of reticular nucleus of thalamus, increase GABA production, and decrease anxiety. So we all know that there's a deficiency of serotonin associated with depression, and meditation increases the serotonin levels. This has been documented. Again, this is not cause and effect, but this is an association. Higher melatonin levels are associated with meditation, and potentially explaining the reasons for why it decreases with decreases of depression. What is the basis for cognitive rehabilitation through meditation? It seems like with emerging technologies such as EEG being routinely used, especially with different kinds of monitors giving you the raw EEG data, the low intraoperative alpha band power has been associated with postoperative delirium, and is also associated with decreased baseline cognition. And with meditation training, it seems like you can actually increase the alpha band power. Acute brain breakdown in the brain network connectivity also is seen, and brain network connectivity has been shown to be improved with meditation. Cortical atrophy, this is one of the landmark studies produced by Sarah Lazar's group from MGH, where they've shown that with literally 6 weeks of meditation or so, that you can start seeing increase in the cortical thickness and the cortical folds with MRI. We have also shown that with meditation, BDNF actually increases, and we all know that there's association with decreased BDNF and postoperative delirium. So this can be the reasons why we can actually improve the cognitive function preoperatively, and we all know that attention, which is mostly deranged in patients with delirium, is one thing that can be improved with meditation and mindfulness, potentially increasing the results from the preoperative period. Yet to do it in a formal study where we can actually improve these results, and that will have an impact on the postoperative period. So we went on to do this guided meditation and looked at EEG at baseline and at 6 weeks. You can actually see that people with novices started showing increased theta band and gamma band. There is an association with theta band with memory, alertness, relaxation, and inward focus and creativity, and with gamma band, increased learning, memory, problem solving, and concentration. So there's a longitudinal impact on brain activity. These are people who just enrolled themselves through clinicaltrials.gov. And you can see with the 32-channel EEG that was recorded on these participants. Now, let's just focus on the sleep itself. We know that decreased GABA and inflammatory markers are very common in the perioperative period. And with meditation, you can actually reverse that. Higher melatonin levels can happen with meditation that can also be favorable for promoting sleep. And meditation is the only non-pharmacological way that can mimic sleep. And we all know dexmedetomidine comes pretty close to that. And Sadhbir Khalsa's group from Harvard actually showed that increased sleep quality and efficiency happens with any type of mindfulness training. And cancer patients, they've done a lot of work and they've shown reduced total wake time, improved sleep quality. And this can be pretty useful both in the preoperative period and in the postoperative period with simple training that lasts for 5 to 15 minutes. Again, need to be studied in a formal way. And Tai Chi has been shown to have increased sleep quality in the old. That is of interest to us. And cognitive-based therapy is being shown to be very useful for insomnia, recently published in JAMA and also in Annals of Internal Medicine. Now, lastly, coming at inflammation, in one of the largest genomic studies that we were involved in during the COVID pandemic, we collected blood samples in over 100 participants who went for a 7-day retreat and took their household controls who had similar diet and usually their spouses and living in the same zip code, obviously, roughly about 30 to 40 controls in them, and did an RNA analysis with the help of Dr. Vijay Chandran from University of Florida. And you can see that STAT genes that are responsible for fighting COVID were turned up in patients who had gone for this retreat, whereas they were the actual ones that were gone down or downregulated in mild or severe COVID. This is one example where you can see that even the gene expressions can be altered with this kind of 8-day meditation retreats and potentially probably important for perioperative inflammation. So I've shown you the reasons for why mindfulness meditation is really anchored in science and can be very useful both in the preoperative and in the postoperative period, and probably one of the most useful non-pharmacological ways to improve our reserves and also help our patients in the perioperative period. So future directions, even though there is enough literature indirectly, we just need to do them in these patients and show that they really work and it's feasible and many people can actually practice it. Taking a pill is easy, but doing this prehabilitation has to be involved. There has to be involvement by the participants, which is mostly a big challenge. Lower pain scores, improve mobility, high-risk surgery, especially cancer surgery, combine the MBA and exercise, similar to what they've shown with cognitive training and the exercise by the Vanderbilt group. Multimodal prehabilitation is probably the way to go forward. So with that, I thank everyone for this opportunity and I look forward for the discussion session. Thank you so much.
Thank you, Dr. Hughes, for that introduction. Hello, everyone. My name is Brian O'Gara. I'm an anesthesiologist at Beth Israel in Boston. I'm going to talk to you today about challenges to feasibility and implementing prehabilitation programs and some things that hopefully we can do to fix it. This is my disclosure slide. So one of the biggest barriers to prehabilitation research is adherence. And we know that adherence is a problem for any patient-led intervention, especially for chronic medical conditions, or in simply just trying to get older patients to adhere to a prescribed regimen of physical exercise. Our cognitive prehabilitation trials to date have been no different. You can expect anywhere between 9% to around 40% adherence, depending on how you define adherence in terms of hours played, number of days trained. But you can imagine if we were to implement these on a larger scale, such as they did in Scandinavia with the finger trial for trying to prevent Alzheimer's disease, that you'd be very disappointed if you had 630 patients in your intervention group and only 76 of them were able to complete the prescribed regimen. So why is adherence so difficult? Well, there can be a lot of barriers. Some of them are cognitive in terms of feeling overwhelmed with surgery and having life stressors that get in the way, especially when you want to incorporate, throw something else in that they have to put an hour into every day or every other day. There can be some technological barriers. We know from our feasibility trial that had we not provided the equipment and the network access, that patients wouldn't have been able to participate, and that the programs are challenging. Both physical and cognitive rehabilitation programs are designed to exercise your body and exercise your brain, and that can be uncomfortable at times for people, and it can make it hard for them to continue doing that. So some solutions to these problems: you can provide the hardware and the software, you can provide the gym equipment, you can provide the gym, you can provide the personnel. Things like personal coaching could really be helpful, and we'll talk about that in a subsequent slide. Making the schedule flexible, so having people do their cognitive exercise according to their own schedule. That could be very challenging in that some patients need that routine or that schedule in order to get anything done. If they're left up to their own devices, they might not be able to train. And then in terms of the cognitive rehabilitation, to have access to multiple applications. So if you get tired or frustrated with one particular element of the program, that before abandoning the whole intervention altogether, to be able to switch to something else which you may find more enjoyable. So on the left here, in terms of personal coaching, are some reasons that patients gave in a study from the Faulkner as to why they thought that adherence to their cognitive intervention was very challenging. You can see some things like lack of positive reinforcement, lack of enjoyment, not having a clear goal. And you can imagine that if you had a coach like Ted Lasso on your team that was always keeping it light and reminding you that you're a good person and that's what's most important, and that all you need to do is to do your best in order to succeed. And adherence would probably be amazing if you had a coach like that, just like the success of the soccer club was in the show. But all kidding aside, also having a personal coach can be very helpful in terms of being able to troubleshoot issues with the hardware, the software, the network, and providing a clear instructions during every session. And having something where there can be a more consistent structure, and that person can also act as a liaison between the patient and the study team, so that problems can be addressed in real time, even remotely. So monitoring adherence is very important, especially if you're trying to prove that it ever happened, as opposed to just taking the patient's word for it. We use Lumosity for our trials, and both I and Dr. Humeidan were a little surprised when we got the data back that was supposed to be tracking gameplay, to find that the dates and times of when the program was started was in the file, but not when the program was ended. So it was a little challenging to figure out exactly how long the person played for. And then no matter if you're talking about the cognitive platforms or you're talking about the physical wearable devices to try and monitor adherence, there's always going to be a question of who's wearing the device and when, what activities are they performing when they're wearing the device. And so some of these solutions to monitoring adherence also come with their own sets of challenges. Potency is an important thing to talk about, especially for the cognitive exercise platforms. So the ones that have been used in the studies to date are designed to prevent age-related cognitive decline or Alzheimer's disease in older patients. It's very much unclear at this point whether or not these programs can be used to prevent delirium or other postoperative neurocognitive disorders. So if we were trying to design a program to prevent those things, I think one approach that would make the most sense is to try and figure out which areas of cognition are most amenable to training. And you can see from this table here that some of those areas might include processing speed, working memory, and verbal memory, but then to also merge those cognitive areas with the cognitive areas that are deficient in patients with postoperative delirium or postoperative neurocognitive disorder. Unfortunately, as we know, one of the cardinal features of delirium is inattention. And as we can see from this table, that attention is actually very poorly trained through cognitive exercise. And so that's a threat to the validity of the intervention in general, is that it needs to be able to train areas of the brain that are trainable, but also we need to be focusing on areas of cognition that are relevant to the perioperative neurocognitive disorders we're trying to prevent. And then after we've designed our intervention, we need to be using tests that will be able to detect the effects of our intervention. So if we're just looking to prevent delirium, of course, there are a number of tools that you can use for that. But you may want to choose one of the tools, such as a 3D cam, that actually will give you some element of the specific areas that the patient is deficient in. If you're looking for postoperative neurocognitive disorder, does using any of these commonly used tests to detect mild cognitive impairment, will any of these actually pick up what you're trying to train or what you're trying to prevent? And the answer in most of those cases is no. And then furthermore, it's important to also include some element of patient-reported outcomes or quality of life to test whether or not the intervention achieves something that's important to the patient as opposed to the research staff or the doctors. And then the last thing that we'll talk about is the time that's needed in order to undertake these programs. So most of the interventions are designed based off of prehabilitation programs for healthy older people. These are exercises that are done typically in supervised sessions once or twice per week for many weeks. And the challenge for the prevention of the postoperative disorders is to try and condense those interventions into the short period of time after which the patient is going to have surgery and before the surgery starts, typically on the order of 1 to 3 weeks. And we know from other trials that it can be counterproductive to include too many sessions per week or too much time in each session. So this can be quite challenging, especially if you're trying to achieve the standard 10-hour dose of cognitive training that was seen in the active trial of healthy older persons to prevent dementia. Now, we also don't know whether or not that dose is what's going to be required to prevent delirium. As we saw from Dr. Humeidan's presentation, it's possible that lower doses of training may also be effective. So in terms of future directions, I think it's really important to improve adherence through designs in both the tech that you're using and also some improvements to the team. The intervention needs to be tailored so that we are targeting areas of cognition that are amenable to training and also relevant to PNDs. And then we need to be using tests that will be able to capture the effects of that intervention, as well as outcomes that are important to patients. So thank you very much for listening, and here are my references.
Well, thanks again to the group for 4 excellent talks. Very interesting. A lot of already conversation going in the Q&A. Since we don't have a whole lot of time, I'm going to just maybe give some rapid fire questions over to the panelists and see if we can answer some of the open ones. And thanks, Bala, for already getting through some of your ones on the answered sessions already. Let's start with Kimberly. There was actually a couple questions about one was omega-3 and another one later on was about multivitamins and trace minerals. So we didn't cover nutrition specifically, but any thoughts on those supplements for cognition or functional outcomes after surgery?
Sure. So I do think a couple of things. One, the clinic that we do our current trial out of is a high-risk surgery encounter clinic, and we are testing levels of vitamin C, D, B12, folate, things like that, and are seeing a lot of vitamin C and D deficiency. And there is some evidence that vitamin deficiencies are associated with worse cognitive function, and similarly to using omega-3s, that it likely is inflammation related. And so I think the omega-3s have been studied probably more than some of the other vitamin replacements and show a lot of promise in potentially helping reduce inflammation and improve cognitive function. So it's something we should definitely be looking at in the future, especially because now there's evidence that it's safe. We've typically steered away from them because of blood thinning properties. And I think it's worth looking into the other vitamins as well, to just kind of complete that whole replacement for patients.
It seems like Chris's mic is muted. Someone unmute him?
Thank you. I'm not allowed to unmute myself, which maybe that's a good feature. My wife probably paid for that. All right, Dr. Humeidan, there was a question about sort of the components needed for the brain training and some of the timing and dosing. Can you speak maybe to the different aspects of the different types of apps and games, and sort of what components do you think are really most useful in them?
Yeah, I think that, it's important to kind of remember that using these types of things for research purposes and what we want to actually encourage our patients to be doing aren't totally aligned necessarily. I don't know that there's not benefit from encouraging our patients to do things like read books, crossword puzzles, take care of their mental health before surgery. All of those kind of softer things in observational studies have actually been shown to have some benefit for protecting delirium. But if we want to actively encourage a promotion of cognitive reserve as a protective factor, then gaming is one of the ways I think we can definitely do that. So games that are dynamic, meaning that they challenge the patient based on their performance, so people don't get bored or disengaged. And that have a very active interaction. So it's not a passive experience, it's an active experience. We're just in the very early stages of understanding, like Dr. Agara was saying, the parts of cognition that we can actively train and how that does or does not translate into benefit for cognitive recovery after surgery. So my take on it is that based on the work in the Neurovich trial, that around 5 hours before surgery in a cognitively normal patient at baseline might have benefit, but I can't say for sure how quickly that 5 hours needs to be delivered, or what the best way to do that is. It a half an hour a day for 10 days or an hour a day for 5 days? That we don't know. But I think that that's a good place to start with research going forward. And based on observational studies and what we know about long-term trajectories of just overall cognitive health, encouraging our patients before surgery to read books, do crossword puzzles, have meaningful social interactions, take up a hobby, those kinds of things probably will have benefit too, and might be a lot more accessible. So studying these things and actually what we can practically do for our patients are kind of two different things, but are both really important.
Thank you. Dr. O'Gara, can you comment about a lot of this data is for patients having major surgery, older patients, et cetera. And there was a comment in the chat about ambulatory patients. We're doing more complex stuff in ambulatory, older patients having ambulatory. So what about these types of programs in ambulatory patients?
Yeah, I'd say that, the rates of delirium, I believe people have looked at this, sort of calling patients at home and doing delirium assessments over the phone or cognitive assessments over the phone for ambulatory patients. The rates are still there. They're lower than for cardiac surgery, for example, or major spine surgery or cancer surgery or something like that. But I think to say that delirium doesn't happen for patients who are having ambulatory surgery is probably a mistake to assume that that's not the case just because they're not in the hospital. And so I think that one of the biggest challenges, like I was talking in my talk, and Michelle was talking about in terms of the amount of hours to play, and Kimberly was talking about in terms of how long you need to exercise for, is when are those patients getting signed up for surgery? When do you know that they're going to have surgery? And how long do you have to sort of to intervene, so to speak, before surgery? So that's one major challenge. And I would also kind of echo what Michelle was saying, is that not necessarily a fancy cognitive application or not necessarily exercising with a Fitbit on. These interventions are recommended for older adults by national medical societies and for healthier aging. And so I think to recommend interventions like these just for the general health of the patient before surgery is probably a very good idea.
All right, thank you. Sorry, I was trying to mute myself to not people hear me typing in the background, and then I got stuck again. Bala, I want to ask you a question about. There was a question in the chat about dexmedetomidine and anxiety score and less anxiety-full cognition. So, sort of tying in anxiety, pain, all that into what we know currently and into future studies.
Yeah, I mean, that's a great question and thought process. I don't think anyone has looked at it the way the comment has been made, stratifying dexmedetomidine effects based on the anxiety scores. I mean, it's clear that higher anxiety leads to poor cognition, especially anybody, leave alone the patient, even for us. But stratifying it and doing it looks like a better way of looking at the results. I have not seen any study looking at it that way, like even doing an interaction. So good idea.
Dr. Rengel, how about the sort of how long before surgery is exercise needed to be effective?
Most of the studies, again, that's an excellent question, and it is one that we really need to work on answering. And there are two challenges that come up with that, particularly in the United States. One is that we really pride ourselves on getting patients to the operating room as fast as possible. And two, sometimes we're racing cancer to the operating room. And so how much time do we actually have? But most of the studies have shown benefit somewhere in the 24 to plus day range, 24 to 30 days minimum, doing exercise 3 to 4 times per week.
Thank you for that. And Dr. Humeidan, there was a question about, so Brian actually pointed out several of the things that, there's issues with a lot of our assessments. So if you're designing a study now with your neuro, background, what would be sort of a couple of your tests that you think would be the best instrument for measuring POCD?
I think.
Or persistent neurologic disorders, we should be calling it now. Yeah.
Right. So, of course, it depends on which window of recovery that you're trying to target. There's some of the literature out there that kind of guides us towards some of the best assessments, because some are focused more on, nursing, for example, nursing assessments versus other types of care providers. So I believe it's Dr. Berger, Miles Berger, had the best practices recommendation that had a really nice table in it with some of these assessments. There's like 5 or 6 of them that are very well validated and can be used. If you're going for delirium and kind of that first week after, certainly the CAM or any variety of that, like Dr. Garza said, the 3D CAM, those are, some of those are very quick and easy to administer. And certainly the kind of the gold standard there. The Memorial Delirium Assessment Scale is nice too, because it has more of a severity associated with it. It's not just a yes or no. Delirium positive or delirium negative assessment. It has more of a quantification to it. Looking longer term, that's one of the challenges, is that historically, if you're going to detect the cognitive recovery that's impaired in a delayed fashion, you almost have to have a baseline to compare to. And that's been the struggle for researchers, is that how often do we get a cognitive battery in our patients beforehand? But certainly, I think that if you're looking for longer term issues, things that engage the caretakers or family involved is one of the good things that we should be looking at. I believe that's called out in Dr. Everett's newest nomenclature recommendations, because historically in the DSM, the family component, or that like caregiver evaluation, or even the patient's self-recognition or awareness of changes wasn't really part of it. And that's important, we recognize now. And then also like your mini COGS and your MOCA assessments, things like that. But I much appreciate the value of a neuropsychologist now more than I ever have before. from a researcher framework. So you should not hesitate to engage those people as well for expert guidance. So
Great, thank you. Dr. O'Gara, how would you go about funding something like this? A couple key things that you'd want to implement, and how would you fund it?
Yeah, so I think, if you're looking to study this, then you're applying for research grants. I mean, the grant that I did the feasibility study on was an internal grant. It's the intervention in terms of the hardware and the subscriptions to the services, like Michelle said, and for me, it was free for research to Lumosity, and so the cost is really for personnel, and it depends on how hard you want to ramp up that element of your program. I think, like most of us have found out in our prehabilitation efforts, if you just leave it up to the patient, then they probably will do a lot less than they're told to, or less than they'll even tell you. And so the coaching aspect is probably, although we haven't really tested this, is probably very important, but also at the same time the most expensive budget item, probably, in terms of getting people to do things. But I think it's also on the research community, those of us on the panel, to prove that it works, right? And so if you can reduce the incidence of in-hospital delirium, which has an excess cost of $30 billion per year in the United States, then we can convince, hospitals and perioperative medicine programs that it's worthwhile, doing an intervention that may cost a few $1,000s per patient if you're going to save, tens or even hundreds of $1,000s of readmission.
Yeah, sometimes it's a lot harder to prove cost savings that you don't see from a complication than it is to direct bill. Dr. Subramaniam, one question I had was, I think a lot of people, meditation is sort of a foreign concept, and you have patients that are coming in for surgery or for something, very kind of clean cut. How do you get buy-in from patients to do some of these therapies which haven't really been mainstream medicine, or at least in the United States in our current practice?
Yeah, one is to have more data. So that will drive the buy-in from the patients. But like you said, I'm not sure how far I'm looking at, it's like empty half or the full half. So I look at people, I feel like there is more and more people actually taking up these things. You don't call it as meditation, call it as mindfulness. Maybe that is a trick. But it seems like if you do that, at least in our studies, we have found 1/3 of the people really take it up and do it. Let's say 100 participants we are targeting. The second third of the people are intrigued, but they're the one on the fence. And the last third, they don't care. So I think this is the usual things that we see with any prehabilitation, simply because they have to do the work. It's not a pill. So that's where the problem is.
And then there was a follow-up question about who administers the mindfulness training in your studies.
So we have a teacher who is trained to do this. She has got a formal training for over a year from a classical school, and she's she's in our center. She's doing all the training via Zoom now for the last 2 years.
Awesome. I think we're already over, maybe just one or two more questions. For Dr. Rengel, I think our assessment of functional capabilities prior to surgery is overall pretty lacking. And so how would you sort of optimize that pre-op testing, or which tests, obviously needs to be fast and efficient, but also worthwhile. So is there any recommendations you have to the group about what tests from a functional standpoint to be looking at?
Yeah, that is a great question that is often debated. I do think that finding a battery that looks at patients' ability to function at home, something like your ADLs and IADLs, just so you get a baseline of where they're starting from. But I do think going forward, it's going to be important to understand which components are sort of breaking down, whether it's strength, balance, or endurance. And so something like performing a short performance physical battery that tests multiple components so that you can understand kind of where you're getting off track is going to be valuable, but it is time consuming.
And because similar question to you, Dr. Humeidan, so preoperative evaluation, everybody who to dive in with a short thing versus a long test, and if so, which battery to use?
So I think there's, pretty good evidence that something pretty quick like the mini cog should be administered to, the recommendation is all of our patients, I think 60 and older, or if they have evidence of cognitive impairment at baseline or risk factors for that. The mini cog is very easy to administer, and if it's easy to score. So if the patients have evidence of impairment there, then that would be who you would want to escalate to some additional workup or testing. We do a mini cog in some of our enhanced recovery protocols at Ohio State, and what we do with that information is, it's kind of challenging because we know from Doug Culley's work that not an insignificant amount of our patients are potentially showing up with some degree of impairment at baseline if they're older. So we encourage the patients to try to keep their mind active before surgery, get their affairs in order before surgery, make major life decisions, and kind of alert the team of their risk. That's really what we're doing with the information right now. So a mini cog is probably the easiest one. Could be coupled in with some other important things like frailty assessments or physical exercise assessment. So, and then we encourage patients to be aware of their risk, and hopefully our research will help us actually be able to do more about that risk going forward.
Yeah, I think right now that's where a lot of clinicians would ask, if I do this test, so what? If I get the results, what am I going to do about it? And I think that's where all of us are trying to answer, at the moment. And I got our last question, maybe the hardest question to you, Dr. O'Gara. If you had to design a trial today with one cognitive prehab intervention, which one would you choose?
Well, that's tough. I would say, but there's two that I would think are the best is Brain HQ and Lumosity. So Brain HQ has data from older patients to prevent dementia, right? And that's the one you're using in your R01. And then Michelle's trial is they use Lumosity, and I think her results are pretty good. So I think you could start with those two and then ask the patient what type of, if you're not providing them the hardware, you can ask them what type of hardware they're using and what type of platform it's on in terms of Android or iOS, and start there, because I don't think that both are available on everything. And then lastly, I would say that having more than one option, and hopefully no one from Lumosity or Brain HQ is on the call, but having more than one option in case you get tired of something would probably help them sustain, their adherence to the intervention.
Yeah, I think that adherence is an important part. And I will say, just for sake of completeness, there is one FDA approved game it's actually for ADHD. That's been approved through the FDA, and that is by a company called Akili. So if you want an FDA approved therapy, different patient population, but some attention deficits were brought up, as that's one of our key things we see. That'd be a third option maybe for people to consider. So overall, I want to thank all the panelists for the great presentations and everyone for joining. I think we had some 300 plus people. I don't know if we got updated numbers after that, but thanks for some excellent questions as well and the interest. And I'm sure we'll see sessions about this live at future anesthesia and critical care and surgery conferences moving forward. So thanks, everybody. Have a great rest of the week.
Thank you.